longevity is an important topic. The objectives are to understand AVF failure mechanisms, learn surveillance and monitoring techniques, and emphasize the roles of technician in AVF care. Now, AVF in hemodialysis, why it matters. I don't have to tell any one of you why it matters. It is the preferred access for long-term hemodialysis. It has lower infection and complication rates versus catheters. As we all know, in an AV fistula, the vein is attached to an artery, and as the time progresses, increased blood flow through the vein leads to arterialization of the vein, and this vein can be cannulated multiple times for the purpose of hemodialysis. A fistula has a juxta-anastomotic segment, a body of the fistula, and an outflow tract. All these places can have issues. Now, AVF longevity, what is the clinical and economic impact? Nowadays, the life expectancy of dialysis patients are increasing. So we are seeing people getting dialysis for years altogether. So if their AVF fails, they will have to get hospitalized again. And majority of the time, they will have to undergo a central venous catheterization, or else they will have to undergo an AVF intervention. So if you care for the fistula and prevent these complications, you can reduce the hospitalization and interventions. And we all know that when the veins are used multiple times, there is increased chance of stenosis and thrombosis in the vessels. So by caring for the fistula, we can actually preserve the venous capital also. What are the major causes of AVF dysfunction? It can be either stenosis, that is narrowing in the body of fistula, thrombosis, that is clot formation in the AVF fistula, and the non-maturation, that is the fistula which is not maturing. This is the artery, radial artery. This is the cephalic vein, and this is the juxta-anastomotic segment. It is the most common site for stenosis. Now, surveillance and monitoring. The essential difference is that monitoring is a routine clinical assessment where there will be inspection, palpation, auscultation. Surveillance is a scheduled instrument-based test to detect subclinical issues. That is either by flow measurement or by ultrasound. So we can simply remember that monitoring is the thing that we usually do. Surveillance is the thing that we may do at some times. Now, monitoring is predominantly by physical examination, inspection, palpation, and auscultation. We all know how to palpate for pulse and thrill. It is always better to use the full hand. And when you are passing through the AV fistula, normal fistula will have a thrill in both the systolic and diastolic. It will be like a soft background. However, in the presence of a stenosis lesion, the thrill becomes more strong. It is seen only during the systole phase, and it will become much more high in the case of a stenosis. Now, this is the arm elevation test. You can see both the hands in this patient. One hand is small and the other hand is obviously bulged. So this guy has most probably a central venous stenosis. So if you elevate a normal patient's arm with a AV fistula, when you elevate that fistula will collapse and his hand will become like a normal patient's hand. However, in this individual, if you elevate the hand also, his hand will again be swollen. So that delayed or absent collapse indicates that there is a outflow stenosis or a obstruction. Now, this is one of the very important tests, that is pulse augmentation test. In pulse augmentation test, we keep both the hands in the AV fistula. With the hand A, we occlude the body of the AV fistula, and with the hand B, we palpate for the pulse. So when you are occluding the outflow, what happens is that increased inflow is occurring into the body of AV fistula, and the pulse will become stronger with the time. So there is increased pulse intensity or augmentation with the when the outflow tract is occluded. That is the normal finding. However, if there is a juxta-anastomotic or a inflow stenosis, there will not be any increase in blood flow into the AV fistula. So there will not be any augmentation in the pulse. So that augmentation in the pulse is the normal finding. If there is no augmentation in the pulse, that suggests inflow stenosis. Now this is the sequential occlusion test. In this we keep both the hands nearby initially and we move this left hand slowly across the body of fistula. So what happens is that when you occlude the outflow, there will be no thrill in a AV fistula. And but once you have an accessory vein, when the occluding hand reaches proximal to that accessory vein, blood will start flowing through this accessory vein. So it indicates the presence of a collateral vein below the point of occlusion. Why is it important? Because if you can detect a collateral vein using this method, and if your fistula is not maturing, or if your fistula is not having good blood flow, then what you can do? You can actually ligate this accessory vein. When you are ligating the accessory vein, the flow in the main body of the fistula increases. So this is the sequential occlusion test. Now coming to auscultation, it is almost similar to palpation, but here we are using the stethoscope to listen along the entire length of the AV axis. Normal bruit is a continuous with both systolic and diastolic hum. It will become high pitched if there is a hemodynamically significant stenosis. As with the thrill, stenotic lesion will cause the bruit to lose its diastolic component. Other significant physical exam findings include prolonged bleeding indicating outflow stenosis, pain on cannulation, hand ischemia, and formation of new collaterals. Now, if I summarize the physical exam, inspection, there should not be any edema, no collateral veins, no aneurysms, no ulcers, no infection, vein visible and straight. Edema, visible collateral veins, aneurysms, ulcers, infection, dilated neck veins all indicates some sort of occlusion. Pulse, soft, easily compressible. Inflow stenosis, there will be weak pulse, strong pulse in an outflow stenosis, absent pulse, that is our nightmare, that is due to thrombosis and it requires immediate intervention. Thrill is a continuous thrill with both systolic and diastolic components in a normal individual. And systolic only thrill is seen in stenosis. Absent thrill is seen in thrombosis or severe stenosis. Bruit, continuous low-pitched bruit on auscultation, high-pitched discontinuous bruit in stenosis, and severe stenosis can have whistling sound. Amelevation test I have detailed, so it indicates outflow stenosis. Pulse augmentation indicates inflow stenosis. Now, what are the clinical indicators that the patient is having significant outflow or inflow stenosis? Arm swelling or pain in outflow stenosis, difficulty in cannulation in inflow stenosis, prolonged bleeding in outflow stenosis, increased recirculation in inflow stenosis, and inability to maintain prescribed pump setting, and drops in URR or KT by V that are not otherwise explained. Now, what is the role of physical exam in early detection? You have to remember one thing. Your fistula is a very superficial structure. So you can very easily palpate and examine this AV fistula. Physical exam is as important as an angiogram or an ultrasound in detecting early dysfunctions of your AV fistula. This early detection will help you preventing thrombosis and loss of access. Now coming to the second part, that is the surveillance. You remember it like that. Monitoring we can do by ourselves. We doesn't need any equipment, but surveillance requires specialized equipments. What are the major surveillance techniques? Access flow measurements, duplex ultrasound, static or dynamic venous pressure monitoring. Now access flow measurement, it is a very tedious process. In this, we have to have a monitor around both the arterial line and the venous line. It will be ultrasound dilution sensors. It will be attached to a monitor. That monitor will again be attached to a computer. What happens is that these probes will send signals back and forth. And initially they will send a signal and they will find out how much time it takes to travel from this here to here. Then they will dilute this flow and then they will see how this flow is changing. With this, they can measure the access flow. If the access flow is less than 500 ml per minute or more than 25% drop, it will trigger further evaluation. So it is like the values will be different for different individuals. On general, if it is less than 500, it is an issue. But the more significant will be previously a patient having good access flow. Now the access flow is dropping. That is more significant rather than a single value. So access flow has to be measured periodically. Now coming to duplex ultrasound, which is the most commonest and most easier way to assess access flow. In this, we use an ultrasound probe to measure the flow across the AV fistula. It can also measure vessel diameter. It can detect stenosis and thrombosis. It is used for assessing maturation and also for surveillance in established AVFs. Duplex ultrasound has to be done early post-creation in week 2, 4, 6 or 10 to assess maturation. When your flow is more than 600 with at least 6 mm in diameter, then it becomes ready for cannulation. And every 3 to 6 months for established AV fistulas. The thing that we have to remember is that duplex ultrasound, this frequently if you need to do this, it has to be present, the ultrasound machine has to be present in the dialysis unit. Then only you will be able to measure blood flows this frequently. And if you make it a point to screen the patients at least once monthly using the ultrasound, then it becomes very easier. However, for the initial time, there is a significant learning curve. It is not easy to measure the blood flow using the ultrasound. And sometimes it requires tedious calculations also. So this is a skill that is achieved with time. Now this is the dynamic venous pressure monitoring. Dynamic venous pressure monitoring is the pressure measured in the venous drip chamber during hemodialysis. It reflects the pressure required to return blood to the patient access via the venous needle. It will theoretically increase if there is a stenosis downstream in the access. DVP has a low predictive value for detecting stenosis in AVF, meaning it often fails to accurately identify the true cause of narrowing. Measurement is highly variable and influenced by multiple factors. Collateral veins in AVF can divert blood flow and lead to erroneous measurements in dynamic venous pressure monitoring. DVP is more useful for AV graft rather than AV fistulas. So what is our role in the management of surveillance? The technician has to perform and document physical exams at each session. Depending upon the unit policy, we have to do either dynamic venous pressure monitoring or duplex ultrasound to measure the AV fistula blood flow. We have to communicate the findings properly. Now, it is always helpful to have a standardized form or checklist, and we have to report the abnormal findings immediately. There is conflicting evidence regarding surveillance in literature. Surveillance will help you to early identify stenotic lesions. However, earlier detection of stenosis lead to early interventions majority of the time. And there will be rising cost also. However, the other people, what they tell is that if you don't have significant alterations in the dialysis patterns, and if you don't have any significant drop in URR or KT by V, there is no requirement to intervene even if your surveillance studies shows decreased AVF flows. So, surveillance leading to earlier interventions is at one end, and surveillance preventing the risk of thrombosis and prolonging the AVF life is at another end. As of now, there is no significant evidence to tell that just based on surveillance findings, we should go and intervene. However, I have told you 6 clinical indicators. These 6 clinical indicators are more important than the surveillance findings. If your patient does have a clinical indicator, it is worthwhile to go for a surveillance technique to measure the access blood flow, to identify whether there is any stenosis or thrombosis. And if both are there, definitely that patient should undergo a procedure. The importance of this is that if you identify a stenosis and if you correct it, you can use the same fistula for cannulation and same fistula for continuation of AV hemodialysis. However, if you miss the stenosis, if the stenosis grows further and it leads to a thrombosis, there will be secondary failure of the AV fistula. The secondary failure management requires the placement of a new intravenous catheter, creation of newer AVF, or significantly cost high procedures to maintain the AV fistula. So surveillance and monitoring are very important. However, what do the guidelines say? 2019 update of the Kedoki Clinical Practice Guidelines states that physical examination has to be done regularly. Training for doing accurate physical examination should be given to dialysis persons. Surveillance for patency, there is inadequate evidence to recommend access blood flow measurement, access pressure measurement, or imaging for stenosis or AVF in AVGs. Intervention should not be based solely on surveillance findings. Endovascular interventions, there is no indication to intervene in AVF or AVGs with the stenosis to improve access patency without any clinical indicators. So the clinical indicators are very important. If you don't have the clinical indicators, there may not be that much benefit in intervening. But this will also change. A new patient who is having a single fistula, it is running for it well for the long time, showing a mild change in AV blood flow is not very significant. However, a patient with multiple access failure currently on a AVF which was working well, which is showing low blood flow, such patients I would still go ahead and do the blood flow measurements and the ultrasound studies to identify. It is reasonable to preemptively intervene in AV access with clinical indicators to prevent thrombosis and access loss. So the purpose of intervening is actually to prevent thrombosis and to prevent access loss. Now, how to overcome barriers? We all are overworked. We do have significant issues. To train for a new thing, to have an ultrasound machine in our unit, to document all these things is significantly time consuming. It will require significant effort from our side. And we have to bother the hospital also to get the equipment. Some alternatives which we can consider are handheld ultrasound devices which can be attached to your mobile monitors, which is very cost effective compared to our routine ultrasound. Then also you require training. It will have a learning curve. It will take some time for us to become proficient in AV access measurement. And of course, the consideration of time constraints. Now, we have to emphasize the teamwork and regularly educate our patients and also our junior staff in needing this AV access measurement. Now, do you have any newer technologies coming up? You do have vascular wall motion monitoring during dialysis and AI-assisted ultrasound to keep track of the measurements that we have received. Now, to summarize, best practice for AVF longevity is to combine physical exam with a DUS, early detection of these complications, and if you intervene, you can actually salvage the AVFs. I would be happy to answer any questions, and with that, I would say thank you and hand over the session back to Sonu.